Okie dokie. Okay, so good afternoon, everybody. My name is June Kim, and I'm with the Association of Asian Pacific Community Health Organizations, also known as AAPCHO. We're a national cooperative agreement funded under the Bureau of Primary Health Care to provide technical assistance to community health centers. We are a membership organization. We have about 29 different organizations that we work with, most of whom are communities that serve a really large portion of Asian American, Native Hawaiian, and Pacific Islander patients. And with me here today, I have Kristen Stoimenoff from Health Outreach Partners, as well as Greg Morris from Peak Vista. Greg's going to be going into a little bit more detail about his organization later in the session, but I did want to give Kristen a minute to just talk a little bit about Health Outreach Partners and give a little blurb on what you all do. I'll just do it from here, and I recognize a couple of your faces, but like AAPCHO, Health Outreach Partners is a national cooperative agreement. So we're actually a national organization that specifically is set up in large part to support community health centers and other community-based health organizations. All of the cooperative agreements have a specific focus, and ours is around outreach. So we do a lot of training and developing resources and one-on-one consulting with health centers around how to develop and run a really effective outreach program that is responsive to the needs of your community, but also meets the business realities of your health centers and your organizations. So we're very happy to be partnering with AAPCHO and the National Health Care for the Homeless Council on developing a training around this. Great, thank you so much. And so we're all here today to talk a little bit more about demonstrating the value of collecting data around enabling services. And so today, during the session, we're going to go into just overall why enabling services are important for your health centers. I think most of you probably know all of that, but we do want to go over the basics. And then we're going to talk a little bit about our original pilot project, the Enabling Services Accountability Project, which is the project that AAPCHO piloted to create a standardized data collection mechanism around enabling services at our health centers. I'll be sharing some of the challenges and benefits that came out of this data collection protocol. And then we're going to talk a little bit about the training of trainers curriculum that I think might be of most interest to you all because it gives you a glimpse into how you can implement some of this protocol in your own health centers. And Kristen's going to lead us through an interactive training activity a little bit later in the session. So let's start by just talking about what enabling services are. We define them as non-clinical services that are provided to health center patients that promote, support, and assist in the delivery of health care and facilitate access to quality patient care. So this is an image from the Jungle Book. I'm sure many of you are familiar with that childhood book. And I credit this image to Molly Mindbreast from the National Health Care for the Homeless because it's a really good example of, on a basic level, what enabling services are meant to do. So here is, I forget the name of the bear. There's a disease. Anyway, so, aiding somebody in getting what they really want to achieve is the premise of our enabling services project. Yes. Sure. I might just hold it. Is that better? All right. Did you guys all get the part about the enabling services? Okay. So basically, this is a definition that most health centers abide by. They're all considered, for the most part, non-clinical services. So let me ask you, how many of you in this room provide enabling services at your centers? Okay, and could I get some examples of some of the enabling services that you provide? Maybe back in that. What was that? Transportation. Any other examples of enabling services that you all provide? Daycare. Health education. What was that? Mental health services. Great. These are all really great examples of enabling services. And so let me ask the people who provide transportation why you decided to provide transportation services when in reality you probably are not getting reimbursed fully for these services.
because transportation services to hard-to-reach areas is very lacking, and so there are real access barriers for patients who don't live in really close areas to your centers. And so this is really consistent with what we see at our health centers as well. We see that providing enabling services really is the crux of what facilitates folks who have real access barriers to reaching your clinic doors. It's what literally gets people into your doors. It also helps to improve health outcomes for the folks who are facing a number of access barriers. And in turn, it also helps to then reduce a lot of racial and ethnic barriers that folks face. For those who are a little bit more pragmatic, enabling services are also considered key components of most primary patient-centered medical home requirements, and we're going to see more and more of enabling services being integrated into the standards that we need to achieve as health centers. So then, why are we advocating for an additional data collection protocol when we know so many of your staff are already kind of at the maximum of what they can do, and they already have so many reporting requirements? We asked that of our health centers, and what we're looking at right now is UDS data from 2011. Be familiar with UDS data. It's kind of our gold standard, I guess, of data collection for the health center program right now. And what this graph is showing is the number of patients accessing services, and what it shows is about 70% of the services accessed by our patients within the health center world are medical services. So that makes sense. We're primary care centers, and that makes sense. But what we're seeing is only about 9% of access services are enabling services. So let me ask you, for those of you who are providing enabling services at your health centers, do only about 9% of your patient population access enabling services? Does that sound right to you? Is that a little too low? All right. And that's very consistent with what we have found at our member centers as well. Unfortunately, we don't have anything really better that shows otherwise, other than our word, right, and other than anecdotal evidence. And so we really believe that collecting enabling services will allow us to, first and foremost, understand how we're allocating our services, what we're doing internally, how much of our actual enabling services staff time is being utilized. Is it being underutilized? Is it being overutilized? Is it being appropriately utilized? And as this data becomes more and more robust, and you can show trends across some time, you're really going to be able to build a business case, right? Because we all know that enabling services are very expensive, but they're absolutely critical to us reaching the mission of our organizations. Yet at the same time, we all know that they're not adequately reimbursed in any way, shape, or form. And so we really want to have that base data to show that this is not an incident that's specific to just your health center, but that all health centers, by virtue of what we want to do, by virtue of the missions that we uphold, have to provide enabling services for our patients. And so we really need that data to advocate for more sustainable funding, to build that business case, and to really demonstrate the value of that comprehensive care that we're all committed to delivering. So, hold on. So this is kind of where we started in 2004. These are the issues that were coming up within our membership. Like I said, we provide a lot of programmatic and advocacy support to health centers that serve a large portion of Asian American, Native Hawaiian, and Pacific Islander groups. And what happens in this community is that because the languages and the number of dialects that fall into this category range over 100, a lot of our health centers end up providing services in 15, 20 languages. And this, I'm sure, is not unique to just our membership, but it is something that our membership brought to light. And what they were saying was that they were spending so much of their time and resources in it, and they were going to in enabling services, and they were going to continue to do so. But they really wanted to have some sort of standard data collection protocol that helped them track this information. And so we started with 4 pilot sites, one in New York, the other in Seattle, and the last 2 in Hawaii, that started from scratch in developing a standard data collection protocol known as our Enabling Services Accountability Project. And over the course of a couple of years, we were able to demonstrate some really great outcomes, and I'll go over those with you in just a second. We started off by collecting categories of enabling services provided, by defining each of these categories and agreeing to them across all 4 health centers, and then collecting data on these 4 categories at all 4 health centers over the course of a couple of years. And the first type of result that we saw was an operational benefit. This is really direct internal benefit. Collecting data on enabling services placed a value on the enabling services team. Believe me, there were a lot of staff that were very resistant to another thing that they needed to collect. But what we found was once the data had been collected for long enough and management was able to turn around that data and show the staff what they were contributing to the organization, it actually kind of built the morale of the department. So I know that that's not, the only reason that will justify collecting data on enabling services, but it really is a powerful tool internally. And what it also, having data allowed us to do was see where all our resources were going. So for one of our health centers, they saw that a lot of their case management staff were spending a lot of time doing managed care enrollment. And so they actually brought in managed care enrollment services and freed up their case managers to actually case manage, right? What a concept. And then in terms of some of our other health centers, they saw that, a lot of, as their populations changed, they needed more language services, and that some of their health education folks were not able to meet the needs of some of the new populations coming in. And they were able to really track that data and find that, for instance, more Micronesian interpreters were needed, and they were able to bring this data to management and advocate and justify hiring on a full-time Micronesian interpreter, which really alleviated some of the burden from other health educators within the organization. Our health centers also use this data to bring to the board and the management, and this data was used by the board and management to really make some more informed decisions about resource allocation within the organization. In addition to some operational outcomes, we were able to demonstrate with this project that enabling services is directly correlated with better health outcomes. So we looked at diabetes, A1C, HbA1c levels, and child immunization rates, and in both cases, we found that patients who received enabling services had better management of their HbA1c levels, as well as were more compliant with the child immunization measures. And just to kind of be on the safe side, what we did was also look at in 2008, we looked at UDS data, and we compared those health centers that spent the most on enabling services. So we took the top 10% of spenders on enabling services and compared them against the rest. And we looked at child immunization, pap tests, healthy birth weight, blood pressure, and diabetes, HbA1c measures. And we found that in the first 4 measures, children immunization, pap test, healthy birth weight, and blood pressure, that the health centers that spent more on enabling services also had statistically significant better health outcomes in each of these measures. So as that project ended, we started to disseminate our findings, and you can find all of this information and more on the methodology of these research studies on our website, which I'm going to share with you at the end, but it's enabling-services.apcho.org, no www. And we started to present on these topics. And what we found was that a lot of other health centers, whether or not they served the same population that we did, really had a lot of the same problems around enabling services and wanted to be part of a larger effort, not just collecting enabling services data in-house, but to also be able to compare across health. So we started to provide technical assistance tools to these folks. The first, I think, thing that we really developed out of this project that was powerful was just a really simple standard data collection category set. We have about 9 categories that all of our health centers agree to measure because these were the most relevant to the health centers that piloted the project. They sat around the table over the course of a couple of months and came up with definitions that they could all live with that really described each of these categories. And they agreed to code. You can see the codes on the right-hand column accordingly, and then come back and compare the data at the end of the year. We also developed a standard data collection protocol. You can't see all of the values, but really it's just a basic encounter form with encounter information, patient information, and at the very bottom, what you see with the chart is just the encounter information and where you can code the codes that were previously stated in the slide, in the previous slide. This started as a paper document, and it has now morphed into several versions of plugin templates for various EHRs. We actually have a next-gen template that is available to just download off of our website, or off of a website that's free for use if any of you are on next-gen. And so with those two basic standard tools, we developed an Enabling Services Handbook and an Enabling Services Implementation Packet that gives you way more information than you probably ever needed to know about how to implement this program at your own health centers. And so we know that the information is all within that packet, and we have actually had, health centers that we've never spoken to just hear about the project, go to our website, download the packet, and implement this data protocol at their own health centers. So we know that it is possible. But for the most part, what we get are requests for training because it's a really extensive packet. There's actually a copy of it going around. So you can see that it's got a lot of information, and a lot of people come to us because they're not sure if they're doing it right, and there are questions that come up that they want a little bit more clarification on, and could you please do a training? And AAPCHO is actually getting overloaded with a lot of those requests, but unfortunately, given our limited resources, the fact that we only had one person who could do the training within our staff, and she was employed maybe like 0.10% FTE to be able to do these trainings, it really limited our ability to meet the need. And so we started talking with a couple of our other national cooperative agreement partners, such as National Healthcare for the Homeless Council and Health Outreach Partners, and we decided to adopt a training of trainers model. So this actually started because Molly and Darlene from National Healthcare for the Homeless approached us about having one of their staff learn how to do the training so that they could spin the training and then train 4 of their grantees. And so we actually have one of the folks at Healthcare for the Homeless trained here with us, and he's going to talk about his experience. And the health outreach partners, because of their expertise in training modules and especially training of trainer curriculums, we were able to bring them in and really have them provide a lot of technical expertise around the best ways to train larger groups of people. So we've been really fortunate to be able to work with these 2 organizations. And I do have to add that we did have funding from the Office of Minority Health as well as the Bureau of Primary Health Care to help support these efforts. So what we're going to do today, there are about 5 different modules in the training of trainers curriculum, and no, we're not going to go over all of them. We're going to go into module 2 a little bit, and Kristen's going to run you through an interactive activity that's guaranteed to get you guys all excited and awake after lunch. So it's just going to be a quick sneak peek at the training where this is actually the last kind of sneak peek presentation that we're doing before we turn back and make the final touches on the training of trainer curriculum that we're hoping is going to be available this fall. It's about a 1-day, 1.5-day training that we're hoping to roll out in conjunction with some primary care associations. So I'm going to let Kristen go into the definitions, and just before, if you all are interested in a national data collection protocol, I just want you to think about 4 real basic questions that you should ask yourself before you jump in. We consider them the pre-implementation requirements. One is really simple. Make sure you're providing enabling services. The second one is, it seems really obvious, but based on some of the challenges that we've seen with some of the health centers we've worked with, make sure or assess whether or not you can get your senior leadership and management on board with this. Greg can tell you a little bit more, but the whole process from beginning of implementation to actually getting some real concrete data takes about a year. It's a really long process, and your staff are going to hate you for a little while because it's extra work. If you're not going to be able to really justify that loss of productivity, that extra time, that extra work, and if your senior management's not going to be backing you up and seeing this as something that's integral to their mission and integral to their development, then I don't really know how feasible it's going to be for all of you. So please consider that. Also, please consider that this is not your only option. There are a lot of health centers out there that already are collecting data internally on their enabling services. You know, the really great thing about this protocol is that it allows us to see across health centers. And in order for us to do that, we have to maintain a little bit of integrity to the original definitions and the original protocol. If it doesn't really sit well with you, then there's no need for you to do it. But if you think that you can manage it, then the result or the payoff is that you're eventually going to be able to compare your health center's enabling services data to, you know, a lot more health centers' data. And that's really going to make more of a case for you later on. And for the sake of your staff, the last consideration that we ask you to consider is to be committed to a clear and consistent workflow and documentation system. Really think this through. Think about how realistic it's going to be for your staff and how realistic it's going to be to change that workflow. If you're going to ask them to do this, are you willing to give them that extra 5 minutes to do it, even though it's going to really kind of cut into your productivity time? If that's not clear and if it's really not carved out for your staff, the results that you're going to get are pretty shoddy data, and that's not going to really help you in the long run. So just consider these. We're not trying to scare you, but you know they're real things that we've run into in implementing the data collection protocol. So that's the website I mentioned before, the enablingservices.apcho.org. No www. You're going to find the implementation packet free to download, all the fact sheets free to download. You can find Tuyen or my information on there if you have any other questions. And also if you need further technical assistance, depending on the patient population of your health center, you can contact Molly Mindbreast from the National Healthcare for the Homeless Council or Kristen from the Health Outreach Partners at any time. So I'm going to give it over to Kristen to run you guys through a fun little activity.
It's going to be really fun. Thanks, June. Twin is going to pass out some handouts for everybody. We are going to go through a few scenarios in a few minutes, but first we're going to go through the definitions. Do me a favor and don't open it up. You can look at the first page, but can you promise not to open it? Well, okay. All right, good. Let me use the clicker. So Health Outreach Partners has been really excited about AAPCHO's work around enabling services data collection for a long time because we provide so much support to outreach programs that are doing so many important enabling services in their communities, and they don't really have a way to show all of the hard work they're doing or the value of the work they're doing. So we were really interested in the work that AAPCHO has done and so happy to have a chance to partner. And we're trying with this to develop, as June mentioned, they have this really spectacular enabling services data collection implementation packet, which is on their website and downloadable, gives you all the tools you'll need, but it's very dense and hard to go through if you don't have some help getting led through it. So if your health center is interested, that would be the springboard for the learning, but you would get help along the way to get trained up. So this little sneak peek is to talk about what the specific definitions of the enabling services data categories are, and how, if you were in your health center or teaching someone in your health center to actually do the coding, how would you go about doing that? I'm going to talk about the details. Greg's going to talk about how it actually works. So I'm really glad that you'll get both perspectives. But the handout that Twin's handing out has the definitions all in one place, and then we'll go through a couple of example scenarios. So June covered a little bit of this table a few minutes ago. Basically, there are 6 broad categories of enabling services. There's case management, health education, transportation, outreach, interpretation, and financial counseling or eligibility assistance. There's also an other category for services that increase people's access to medical services but don't fall under these categories. And then you'll see that within case management, there are 3 separate types of case management services. And I'll show you in health education, some health centers actually subcode health education. But that all makes sense in a second. So the first category of case management assessment is, the key here is these are all enabling services helping people get to medical care. So it's not going to be a medical assessment. It's a non-medical assessment like a psychosocial assessment or a new patient assessment, and it helps assess things outside of someone's medical status. Do any of you do case management assessments in your organizations? We have one hand, a couple people. Okay, so if you're doing a case management assessment, we'll talk about how to code it in a minute, but that has its own category. There's also a case management treatment and facilitation category, which really goes into developing a treatment plan and facilitating access to other providers. Again, it's talking about facilitating access to health services, case management around health type services, and it may include a referral or a series of referrals to folks. But in the third case management category, which is just case management referral, if all you're doing is a referral, you just code it as a referral. So we'll see some examples of this. But if, for example, you were doing case management, treatment, and facilitation around somebody's, I don't know, name a condition that you do a lot of case management facilitation around. Diabetes. So maybe you're putting together a case management treatment plan for diabetes, and then you want to refer someone as part of that to the nutritionist. That all goes under case management, treatment, and facilitation. But if you just made a referral to someone to the nutritionist that didn't have to do with you putting together that treatment and that treatment plan, you would just count it as a referral. Does that make sense? The next category, and everybody's talking about this right now, but the eligibility assistance, right? For the folks who are in community health centers, you may have submitted outreach and enrollment grants. You're probably all going to be doing you're probably already doing a fair amount of eligibility assistance, and you may be doing more. This can either be helping people figure out if they're eligible for health insurance programs or prescription assistance programs or your sliding fee scale. But if you're doing stuff that helps people figure out what sort of financial resources can help them access care, it would go under this category. Health education, there's just one broad code, but some health centers in the Healthcare for the Homeless pilot and the AAPCHO pilot decided to break it down into 3 subcodes, so I'll talk about that in a second. But the overview is that you're providing health education or supportive counseling using behavior change methodology, really trying to help people make a plan to change their behavior. Some programs were doing so much health education and in so many different ways, they wanted to capture a little more detail about that. So everything falls under the health education category, but unlike case management, which had 3 separate codes, this has 3 subcodes. So for all of them, you're doing health education, but you may choose to say, I did health education in a group, and that means up to 12 people. Or you may choose to say, I did health education with an individual, and that's just one person. Or in the case, I think this was with a lot of the Healthcare for the Homeless programs, there was so much supportive counseling that was happening. They wanted something that was a little more specific than health education, and they subcoded that. And in some cases, I think maybe even created a separate category in other. So with health education, you can just use the one big code, or you can decide to get a little more specific and say I did it with an individual, as a group, or a supportive counseling situation, which might be something like counseling, doing family counseling for a child who's just been diagnosed with cancer and you want to give them some support around that, or domestic violence counseling or something like that. It would be a little more in-depth than health education, and you might choose to code it a little bit differently. Interpretation. How many of you do offer interpretation in your health centers or in your programs? Quite a few. So when interpretation is provided, you're talking about, when it's oral interpretation, a third party. So you have an interpreter in the room interpreting between a medical provider and a patient. And again, we're talking about the medical visits here, not interpretation between a patient and a homeless shelter employee or something like that outside of the health center. So if you have an interpreter in the room talking between the patient and provider, that's interpretation. If you have a bilingual person talking to someone in a language other than English, that's not interpretation. You are providing important language services, but you wouldn't count it as interpretation. And we also count as interpretation if you're translating something for a patient. So if there are instructions on their pill bottle and you're translating that, that would get counted as interpretation. Outreach is very specific, and there are a lot of outreach services that we know health centers do that go beyond this. And we're very, very happy and would like to help you figure out how to code beyond this. But for the purposes of this project, you would only code as outreach, something that involves getting a patient enrolled into getting a non-patient or a patient who has not been seen in a long time enrolled into your health center. So if you do a health fair and you have a mechanism for getting a new patient enrolled, you would count that as outreach. If you just did a health fair and handed out a bunch of brochures and didn't actually have individual contact with patients and didn't actually collect any of that information and convert someone to a new patient, that wouldn't get counted. From an outreach TA provider's perspective, I do know that your outreach programs do so much. I hate to see a lot of that get lost. So we would love to, we're working with AAPCHO, and we'd love to work with any of you to figure out how best you can also track those other outreach services so that all of your time is adequately accounted for. And finally, transportation services. And that's providing direct transportation to patients to or from their medical visits. Doesn't include things like taxi vouchers or bus tokens, and it wouldn't include transporting someone to a shelter. But if you're picking up a patient and bringing them to the health center or to a specialty provider or something like that, that's where you would put transportation. And other is other. And we'll see some examples of other in a few minutes. Do you have a question? Yeah. So you're giving them the voucher and somebody else is doing the transportation, right? Got it. Yeah, so it would not count. It wouldn't count. Because what you're trying to do is track your time in providing the services. And, it's really interesting, this issue of transportation. What's that? They have to document it. They have to provide it. We'll talk about that a little more in a second. But yeah, so that wouldn't be counted as a transportation service. Does anyone else have questions about what we've gone through so far? Okay. All right, are you ready to have a little fun? Here's what you have to think about. And we're going to go through some exercises. And I'm going to have you work in pairs or small groups. And this room, you're welcome to move around if you like, but I think you could just work with someone next to you or turn your chair around and work with someone behind you. We're going to go through a couple of scenarios, and we'll do the first one together and then have you work together. But here's what you have to keep in mind when we code these things. couple of rules, and this gets to what was just asked. The service has to be provided by someone at your center, a staff member or a volunteer or a contractor. So if you're giving a voucher to someone else to do it and it's totally outside of your health center, that would not be counted. It has to be linked to a medical patient. So that's why a lot of these outreach services that don't get a medical patient in for care, that's why they don't count, because when AAPCHO created this project, they really wanted to show how can we prove that our services increase people's access to care, decrease health disparities, improve health outcomes. And if you don't have a service directly linked to a person, you can't prove that. So some of the stuff, has to be really focused on care to a patient by a provider. It has to be provided directly to the patient or the primary caregiver. So if you're doing something for parents on behalf of their children, that would count. And there's a form, and we're going to practice the forms. You fill out one form no matter how many enabling services you provide. So you may do 2 or 3 things. You wouldn't have to fill out a different form for everything. You just put them all in the same form. And then in terms of time, when they were developing the protocol, talked a lot with the stakeholders and decided we really need to have a cutoff here. We're only going to document things 10 minutes or more, because honestly, if we documented things that took 3 or 4 minutes, we would spend more time documenting this stuff than we actually spend providing the service. Some health centers have felt really strongly that they do lots of things that might take 5 or 6 minutes, and they want to document it. So they've addressed that by creating an additional 5-minute increment category. But when it comes time to analyze the data, they still need to be able to pull out only the 10-minute increments. It's a little bit technical, but I just want to give you a sense that the protocol calls for only doing 10-minute increments, but if you feel really strongly about also counting less than that, there's a way that you can do that, and AAPCHO can show you how to do it. Uses the rules of rounding. If you remember, I don't remember what grade I learned that in, but if you spend 16 minutes on something and you have to round to the nearest 10, how many minutes would you document? 20 minutes. And if you spend 22 minutes on something, what would you document? What's that? 20 also. So with the rounding, if you have from 1 to 4 rounds down, and from 5 to 9 rounds up. Any confusion around that? Okay, that's very good. Okay, so here's a sample encounter form, and now you may turn the page. This is a really simplified version of what June showed you earlier. What you would have either on paper or in your practice management system or electronic medical records would also include information about patient demographics, and you can set that up however you want. AAPCHO's member health centers had very specific demographic categories that they were able to include, and Greg, I don't know if your folks created their own demographic categories, but a lot of that is very customizable. This is the stuff that everyone has to do in a pretty standard way. So what we're going to do is read through a couple of scenarios and make decisions about how they would be coded. So the first one, scenario 1, I will read it out loud for the sake of the recording. Normally I would pressure you guys into reading it for me. But scenario 1 is that a 42-year-old male patient whose primary language is Korean walked in your health center without an appointment. First, you spend 23 minutes translating between the physician and patient during the exam. He's diagnosed with hypertension and is prescribed medications. After the appointment, you spend another 18 minutes explaining in Korean a brochure on hypertension that is written in English, discussing the condition and treatment in more detail. We have 3 questions to answer. One is, what type of encounter was this? Face-to-face, telephone, or off-site? If you have to choose one of those, what do you choose? Face-to-face. So go ahead and circle face-to-face. the next question is, it's really a yes-no. You want to document whether or not there's interpretation provided. You want to document whether or not you're providing services in a language other than English. So in the case of this, yes or no, was the service provided in a language other than English? Okay, so you check yes, and then you would write in Korean. And then we have to decide how to code it. So any thoughts about how to code the 23 minutes that he spent translating and 18 minutes explaining the Korean brochure on hypertension? Okay, I heard 120 and 20. What are some others? So how would we code it? We know that he spent 23 minutes translating between the physician and patient and 18 minutes explaining a brochure in Korean. So the brochure is written in English, and he's explaining it in Korean. Okay, UCHE001, how long for that? Okay, I hear some 20s. I heard 140. I hear a couple more 20s. We're deciding how to do it. I think the 40 person combined both. So I heard a lot of 20s. For the person who thought 40 on health education, what was your thinking there? Okay, so 20 minutes health education is correct, and that's the part where he was explaining the brochure that's written in English, but he was doing it in Korean. He wasn't interpreting it directly, but he says, you know, here's a brochure on hypertension, and I'm going to tell you about it, and I'm going to tell you about it in Korean because I know you speak Korean, and so do I. But then he spent another 23 minutes doing what? Interpreting for an actual medical service, and that's different. So you code that differently. So how would you code that? Yep, so that one is IN001, and that's 20 minutes. So you have the 20. Yeah. The other one's also 20. That's where the rounding comes in. So he translates for 23 minutes. That's the interpretation code, but we round down to 20. Because anything from 1 to 4, you round down. Anything from 5 to 9, you round up. Does that make sense? So 23 rounds down to 20. And 18 rounds up to 20. Well, but the enabling services provider did not do the treatment. He got treatment from a medical provider, but that would just be coded like a regular medical visit. So the person who's doing the interpreting and the health education, they don't code that stuff at all. This is just to capture the time that the person who's doing all these other important supportive services is spending. Yes, you can't double count. Yeah, you can only count everything once, and you have to pick the best, right? Sometimes it feels like a gray area, and we'll probably see another example or two of that. But some people, when we presented this a couple of months ago, really wanted to count it both as interpretation and health education, you know, one of the exact same services. And they said it takes a really long time to do this stuff, and really you have to be very faithful to the amount of time spent. So you do have to make a decision. Mm-hmm. If they were specifically translating, if I sat down with the medication instructions in English and said, okay, this says take 2 times a day, every day for 10 days, and I said that in the patient's language, that would count as interpretation. Well, also I mean, do you have
Benefit treatment.
it's direct. It's like literal, yeah, that's where with this brochure, I think to me the implication is, I'm not translating this word for word. I'm saying, okay, here's some information on diabetes. It talks about the fact that you can get diabetes because you have hereditary issues, or it might be a blood sugar thing or whatever. You're summarizing, you're explaining it broadly, but it's not a word for word. Mm-hmm. The gray area is rubbing you the wrong way. The translation part. Sure. Well, the nice thing about this is no matter what, you get to say, we provided that service in a language other than English. So that's going to get captured no matter what. Like whether or not we're going to call this interpretation, she did that in Korean, and we want to make sure to capture that. But yeah, when there are gray areas, you really have to work out with your staff what's the exact best way to do it, because they've certainly found in practice there are so many different scenarios that you couldn't possibly think of for the instruction sheet that, yeah, it becomes figuring out how best to fit it in, or would you not even count it as an enabling service? Yeah. Mm-hmm, mm-hmm. Mm-hmm. Yeah, if you want to, right, that's why June went over the, what do you call it, right, the things you want to really think about and commit to before you put yourself into the sort of difficult but super worth it process of doing this. If you decide you want to make sure you can feel good about committing to that. Yeah. That is a really good question. She asked it when we're talking about enabling services, does it have to be provided by certain types of roles, or can it be provided? It can be provided by anybody. We have found in migrant health programs, lots of outreach workers, health educators, case managers do most of the enabling services. In healthcare for the homeless programs, lots of physicians do enabling services.
I did 91% of it.
Yeah, so certainly we want to capture that. And if he can't code his services as a clinical visit, it's still great to be able to code what he did. It doesn't matter who does it. If it's an enabling service, not a clinical service, and you want to do this, code it.
And we wanted to set up coding enabling services as an enabling service itself, just because every time we rounded up, I always came out with 4 hours for everything. So.
Great. So don't really do that, but it's a good idea. You know, I think it is, okay, so what I'm going to do, I wanted you to work in teams, but there have been so many good questions. I think we should go through one more scenario together and then let Greg talk about his experience, because I think you'll really appreciate hearing it from someone who actually has done it. So let's just go through one more so that you can understand it just for a couple of minutes, and then I'll turn it over, okay? Okay, so let's see. I want to find another hard one for you. Maybe I won't get into too much hard stuff. Okay, scenario 2 is hard. A 34-year-old female patient from Mexico has several conditions, including diabetes and back pain from her work in the tomato fields. She and her husband are both undocumented, and they have 2 young children. During her most recent scheduled visit, you first spent 8 minutes to assess her children's eligibility for Medicaid. Then you spent another 34 minutes to develop a medication management plan for her. During the visit, you also spent approximately 17 minutes to arrange a referral to a physical therapist for her back pain. You are bilingual in English and Spanish, and you provided all the services to her in Spanish. Okay, so the form is on the next page. First off, face-to-face, telephone, or off-site. Excellent. Secondly, service provided in a language other than English, yes or no? So check yes and write in perfect. Now, how do we code it? Remember, one form for all services, and remember the rules. Okay, raise your hand if you want to start making a guess, and I'll go ahead. 10 minutes for financial, so that would be FC001, 10 minutes. Does everyone agree with that? Does anyone have a different idea about that? Liberty? So, we should say what it's for. So the 10 minutes, can you say specifically what you were coding as 10 minutes financial? Yeah, that was assessing her children's eligibility for Medicaid, was where she was suggesting 10 minutes for the financial counseling. And then the person did other things. So there are a lot of things going on here. Did Liberty, you have a comment or question? Oh, that's a good question. Right. You know, we've definitely coded this as eligibility assistance financial counseling, right? But in the implementation packet, there's a lot more detail about all these. No, it's a really good question. And another thing that came up for me, because I automatically coded it as 10 minutes financial counseling, and I created this scenario. Then later, I realized, wait a minute, they did it for 8 minutes. We shouldn't even count that. But some health centers really wanted to count less than 8 minutes, so you could count it, but you'd have to use that anyway. So, yeah, because you need to count the number of. In that case, you might just do a count. You know, you don't have to report on the time, but you may want to, which is fine and great. But at a minimum, you want to count the number of people you assisted. Okay, so we're going to say yes to 10 minutes for financial counseling and eligibility assistance. What about her 34 minutes developing a medication management plan? CM002, how many minutes on that? 30 minutes on that. Does that make sense to everybody? You put health education for that? So this fit most neatly into that case management, treatment, and facilitation category. Sometimes there are gray areas, and if it had said we spent 34 minutes talking about diabetes and how best to manage it, I would put it under health ed, but since it talks specifically about developing a medication management plan, I would go with the CM002 at 30 minutes. And what about the 17 minutes for the referral to the physician? Yeah, it's CM003, 20 minutes. It's the case management referral, 20 minutes. Now, here's the thing. If that referral, this referral was to a physical therapist for her back pain, if it had been a referral to a nutritionist as part of the overall diabetes care management plan, you would just count that within the diabetes treatment and facilitation. Remember how we talked about a referral within the context of treatment and facilitation got included? But since the referral is for a totally separate issue, we count it as that case management referral code. if it's to a medical, for a medical visit, right? So if it were a referral to like a nutrition support group, like an exercise support group or something, you wouldn't necessarily count it. But yeah, for a medical, for a specialty visit outside, yeah. Sure. Sure. Yeah, yeah, and those are definite, and that again goes back to they really wanted to have a data set that would prove improved health outcomes and improved access to your health services as a result of the enabling services provided. So, you know, going through those issues are things that you have to talk through with your health center. You know, I would suggest, because this is such important stuff, but we really don't want to lose access to the person who's done it on the ground, I would suggest definitely coming to us after, and we can talk more about this. They're very important issues, but I think it'll be valuable for you to hear how someone actually did it. So let's turn it over to Greg, and we can definitely have those conversations after.
Are my slides on the same?
I think, are they?
Because I thought you couldn't incorporate them.
So that is one of the major issues that we're seeing in a lot of clinicians getting to the question. What about the validity of the data? So at this point, we do our best to try to make sure that folks understand where the flexibility is, but also how important it is to the initial investment.
And what we were involved with was actually more the development of the protocols and how to implement them and track them and who was going to do it in that part of the study from that standpoint. This slide has nothing to do with anything about the talk. I think my wife actually just slid this in there so that I could actually get the weeds out of the undergrowth, make sure I filled the bird feeder, and finish the patio up above the house. So. Reminders. Yes, I had an entirely different slide there. So that's me. I have like lots of hats. I actually am involved with the Clinicians Network Steering Committee, which is a standing committee for the National Healthcare for the Homeless Council. I was chair of that a couple years ago. I will kind of slow down because I think I had this timed out at around 20, 25 minutes, but it'll be about 12, which is as fast as I'm going now. So, Peak Vista's Homeless Health Center is actually a standalone homeless clinic. We have primary employees, myself and 2 MAs that actually take care of the entire homeless population that visits us. We have 1,500 individual users and about 3,400 encounters a year. And that is with clinic hours being at about 24 hours a week. Because of limited funding, we're actually not operating at 40 hours a week. So if you extrapolate that out, it's roughly double that as what we would serve in a normal period of time. But what we do actually to make up for that is we have a medical van, which is probably the epitome of enabling service, in that we take a medical van out to the soup truck at night for those that can't access services during the day, and we also go out into the rural areas and take care of the high-risk, near-homeless individuals that are 30, 40, 50 miles from town that literally have to make the choice on whether they put gas in the car or come into town and pick up their medications and continue their health care. So, and we actually still do outreach. That was kind of the cornerstone of what we did before. We did outreach to the camps. When you talk about outreach and services, I mean, we would go out to the camps, establish relationships, and try to get some of the chronic individuals off the streets into the clinic and start to take interest in their own health care. So, for example, one example of the enabling service is to be able to call and maybe encourage someone to come in for their colonoscopy and whatnot. I would go to the camp. I would target individuals in certain age groups, say that you need to come in for a prostate exam, whatever was prudent as far as preventative medicine. If they didn't want to, I offered to actually do the exam in the camp, and they actually agreed very quickly to come into the clinic. So. But actually, it actually boils down to trust and getting them to come in. So, the homeless encounter is actually no different in the homeless setting as far as patient encounters. Provider-patient encounters are the same. They're driven by more encounters, more billing, see more people, because then that way you can sustain your funding, you sustain your need, and which I find tremendously ironic, because if we're truly trying to end homelessness, shouldn't we actually get more funding and bonuses for seeing less people from that standpoint? And so how the encounter feels, whether it's a homeless setting or community health centers or more affluent practices from that standpoint, I think is the same across the board. So if I can borrow you, you can actually see how an encounter feels to the provider themselves. So they actually come in, I introduce myself, I'm Greg Morris, physician assistant, Big Vista Community Health Center. How may I help you today? Boom. Take this 3 times a day. I'll see you in a week. Boom. And step back, throw your hands up. It's the same as a rodeo and actually calf roping. Boom. You get them done and you move on to the next page. That's how it feels. So when we're talking about enabling services, you're trying to implement that in and around the patient encounter. Well, I know from the administrative standpoint, they feel that actually encounters go like this. Introduce yourself again. My name is Greg. Well, there's middle ground there. All right. So, in the homeless setting, that is, enabling services are what we do. And so what we focus on is anything that will actually allow a homeless person to access all of the services that we provide, even right down to making sure that they do follow-ups, and whatever it takes to be able to keep them interested in their health care and to keep follow-up appointments. So we've been doing it all along from that standpoint. And even what we've done beyond the enabling services that are actually part of the study. So we have actually gone out to camps to bring them into their appointments. We'll take them to their follow-up appointments. We do extensive education within the patient encounter. We've been doing that all along. So when the National Healthcare for the Homeless Council had come to us and approached us on actually doing a pilot study to be able to track what those enabling services are with the potential of getting reimbursements for providing those services, that is what we did. It was kind of unheard of to us to actually get reimbursement for the time that we spend outside of the patient encounter to enhance those services and increase the likelihood that we can actually keep the homeless client engaged in their health care. And so, as stated before, we were trying to determine how much time we actually spend in the clinic setting providing these enabling services. We actually had no clue. We just did it. It was second nature for us. So the implementation, it was kind of interesting. I mean, I just said that we kind of jumped at the study or the chance to be able to do the enabling service, but the implementation was quite different at the ground level. So in the practice that we have, as I said, it's myself as the main provider, and we have 2 MAs that run the front desk that actually do all of the logistics of getting a patient checked in and back into the room, seen, and education going out the door. With that, we're an open access clinic, and so we're actually the epitome of open access. We unlock the door in the morning, and the entire patient schedule is there waiting for us once we come in. We tried to do appointments at one point, but I think the no-show rate was around 70%, so we actually almost lost our funding because we were trying to do appointments, and we haven't been able to find some type of middle ground, even trying to backfill appointments from that standpoint, to not make it so that homeless have to line up in the morning and kind of wait for the door to open. So once I kind of approached the staff about doing this and kind of what it was going to take, and that we were going to have people come in and do the training. I mean, initially there was kind of some pushback, and the look was, for a couple of weeks kind of like this. It's not like we don't do already enough as far as this goes. You're actually going to put in this regimented thing on top of the time that we already expend doing what we know we already do. I don't know if we can do that. But they uncrossed the arms, over a period of time. And actually when Darlene Jenkins and Molly Mindbreeze came in and went over the whole training protocol. And actually we went through exactly what was presented through the previous guest speakers. We went through this diligent 2-day training on what the enabling services were, what we had to track specific to time, what qualified as a specific enabling service. The arms crossed again from that standpoint for a little bit, but we were able to slowly get them tuned into having that in the forebrain as far as bringing a patient in, doing their normal daily activities, and then actually looking over to see, okay, so what enabling service? And that's the part that was really kind of hard, because just like you went through with those previous scenarios, I mean, the staff really had to go to their sheet book almost with every patient that came in, see if what they were doing was an enabling service, and then be able to put it into the computer and track it accordingly. As far as implementation as well, that was also another barrier. We are a stand-at-home homeless clinic, but we're part of this conglomerate community health center, which sees like 70,000 patients. It has a patient base of 70,000. We compete with 12 to 15 other clinics for business intelligence, which is any type of data tracking that we need to have specific to our program. So you have to put in work orders. You have to actually schedule and set up time to be able to meet with these individuals to see what this process is going to look like. And it was what initially was going to be just a few weeks to be able to implement this, actually was over a period of 2 to 3 months. We were supposed to be up and completely running by January of 12, but we were still actually trying to put the process in place by then. Once we did, though, it was actually phenomenal because we used NextGen as our electronic health record. They were able to put into a drop-down counseling segment or tab within the electronic health record everything that we were trying to track as far as enabling services. So each line item was there, and we were able to put in the minutes that we had taken to do that specific enabling service. As far as determining what that was with each encounter was a whole entire different story. But once that was in place, once we actually got used to the process, then it became almost second nature. So we were actually using our little cheat book a little less and getting the data that was needed for the pilot study. So the criteria actually then was actually what was mentioned before. So we were tracking, case management assessment, case management treatment, case management referrals, financial counseling, eligibility assistance, health education, interpretation services. And what we mean by interpretation services is that there was actually someone to interpret me for the client or the patient that was in there. So, because I talk like this all the time. Outreach services and transportation. Now, we specifically had an issue with the transportation component because even though they had a clear and defined idea of what transportation is, we thought that transportation, if we're giving bus tokens, we're giving cab vouchers for that client or patient to actually get to radiology to have an x-ray or to their physical therapy appointment, that should count. So, but I don't think it did, so we followed the protocol like we were supposed to. And actually, I just encompassed what the barriers were from that standpoint. It was actually trying to get everybody on board, all coordinated, everybody to buy in, and how important this was to the homeless clinic and the community health center as a whole to be able to, hopefully down the road, bill for these types of services in the time that we expend to do this. So the results. Ideally, I would love to have some slides for that, but because of the work orders and the aforementioned business intelligence time that it takes to actually get those, I have the sheet here that actually... So, the participating sites in this were Charles Drew Health Center in Omaha, Nebraska, Peak Vista Community Health Center's Homeless Clinic, Harbor Homes in Nashua, New Hampshire, and Jackson Hines Comprehensive Health Center in Jackson, Mississippi. So, we looked initially at the big picture, which was data collection time, or time period, enabling services provider visits that were documented, unique patients receiving enabling services, and providers documenting enabling services. In comparison to like Charles Drew, the time period was October 11 to February 2012. Their enabling service provider visits were 749. Unique patients receiving these enabling services were 376. And providers documenting the enabling services were 12 within that health center. Peak Vista, for example, from January to March of 2012, the enabling service provider visits documented were 74. That was really kind of pathetic, but that was also a testament to the slow ramp-up time and the logistical issues that we had getting up and rolling. And by the way, the numbers now were phenomenal after the pilot study. And the reason why that they were phenomenal, and they actually caught up over a period of time, because the pilot study did stop for most of these centers in, I think it was March 2012. It was like a 3-month pilot. So, and the key to that was that I actually never told the staff that the pilot had ended. So I kept getting the numbers back. They were very comparable. Unique patients receiving enabling services, 65 at Peak Vista, and providers documenting these enabling services were 4. So I think the other person that actually snuck in there, even though we were a 3-person practice, there was a physician that covers on Fridays, which is my day off. So who is providing these enabling services? Charles Drew, for example, had medical providers do it 70% of the time. Transportation was done 13% of the time, and I actually never knew what that meant. That was unique to Charles Drew. So I don't know if the cab were actually charging for us, the cab drivers, or mental health, behavioral health staff, 11%. Outreach workers were doing it 6% of the time. Harbor Homes was actually more diverse. Outreach workers did it 26% of the time. Financial staff actually did it 40% of the time. So I found that really interesting. Administrators were even doing it 28% of the time. Their medical providers only did it 28% of the time. So, and I don't know what that's a testament to. So how much health education were they actually doing in the patient encounter? So, and Peak Vista, 91% of the time it was moi, and the medical assistants did it 9% of the time. But after the pilot was done, those numbers began to turn around. Who is receiving enabling services? The median age range was 42 for Charles Drew, Harbor Homes 42, and Peak Vista 48. The gender split, 62% male, 38% female, almost across the board. And the race breakdown was white 71%, 18% black, and 11% other at Charles Drew. Harbor Homes was 91% white, 1% black, and 8% other. And at Peak Vista, it was 82% white, 10% black, and 9% other. You know why they just cut it off at other from that standpoint? So, I mean, because we have actually a pretty strict need to break down demographically exactly who we're serving across the board. And to continue that, primary language was English at 98% across all of the participating parties, 1% Spanish, and 2% other. So I'm wondering from that sense, so in the future, are you actually going to be able to use, I don't know if you're still tracking data from that standpoint?
Lots more is collected, so I'm not sure
Okay.
how that was compiled, but there's a lot more detail.
Yeah. I think my point was is that if you're actually really trying to track interpretation services, if there actually wasn't a lot within the pilots utilizing that, are you able to reflect on the true need of interpretation services and the need to reimburse from that standpoint? So. Payer source, ACH grantees, 96% at Charles Drew, 5% at Peak Vista. Medicaid, Medicare, 1 to 3% across the board, and other, 3% at Charles Drew. Peak Vista has 92%. I think there's only like one more is fine. So, and then we finished up by actually allocating percentages to the specific time spent in the enabling services. So, for example, case management assessment, 4% of the time was spent by us doing that type of enabling service. Case management treatment, 7%, and the average was 17 minutes, 13 minutes. Case management referrals, 41%, 10 minutes at a pop. Eligibility, financial counseling, 3%, although I think that would look completely different now because at the homeless clinic, we are actually a site for registration for Medicaid for adults without dependent children, which has kind of been a godsend for our patients accessing some type of benefit. And with Colorado now playing into healthcare reform and actually establishing Medicaid as that vehicle to do so, we're kind of ahead of the game. We've actually seen our payer source change within the past year because we used to have only about 4% Medicaid, and I think we're up above 26% now, so slowly getting there. Health education, supportive counseling, 45%, transportation, 1%. Because most of the transportation and whatnot that we did didn't qualify. It is, really. So I don't mean to harp on that. So conclusions. At least in the healthcare for the homeless setting, enabling services are just paramount for a homeless person to be able to. I mean, I don't know if I threw this out earlier. I mean, what really drives us is actually one statistic. The average homeless person lives 33 years less than their house counterpart. Brass tacks, I mean, that is the big target that we shoot for. All of these enabling services allow us to keep a homeless person engaged in their own health care, into their appointments, stay on their medications, decrease the morbidity, decrease hospitalizations, decrease ER visits, and allow us also then to focus on getting them into housing. So if we can actually get a bump in reimbursements to provide these services, I think it can only enhance that. I think I heard at one point that Peak Vista, the community health center, spends annually upwards of $2.4 million on what they consider enabling services. So that's a huge piece out of your budget yearly. So that's my spiel, and I'll stick into it.
Yeah, so I just wanted to mention that, are the other evaluations have that? Yeah, so you have evaluations, I believe you have two. One's a post-evaluation for this conference, and then the other one is a project evaluation, and that's for us as trainers. We're going to implement a lot of the suggested changes into the training curriculum. But anyway, while you guys fill that out, we're happy to take questions if there are any.
And just quickly, coming in myself will be collecting the survey. So